Good morning to everyone. This is the second version of the lecture entitled Analgesia and Sedation Management as part of your master's course in osteocritical care. The reason for the second version is that I had introduced some more slides between the time I submitted the first PDF and subsequently presentation yesterday. Now, just a couple of observations. As you know, in the last 2 weeks, we've had brilliant case presentations. The first from Dr. Sanger at KCMC in Tanzania, talking about head injuries in a management in a low-resource company. And also from Dr. Chris Carter in Zambia, talking about a 40-year-old who had been involved in an RTC and was being repatriated back home. The reason why I wanted to bring back these two presentations is that I hope today's presentation will start putting questions in your mind and reflect back on those two presentations as they are all interlinked. My job is to give you a brief on what is happening in the intensive care world. And then the second half of the presentation is what we can do in a low resource environment using the minimum, better, best concept that is now available in PFC. As you're doing a master's course, I can only give you my biased opinion. It is up to you to decide as to whether my opinion stands or can it be replaced by what you've experienced, learn from other resources, etc., etc. And that's the beauty about this course. When you're doing your Gibbs reflection, try and be specific about a positive point or a negative point. In other words, what you'd like to introduce into your clinical practice, or what you'd like to avoid in your clinical practice, so that you can get further benefit from these strategies. Even if you happen to be working in an environment that is not in a resource limited, it is often useful to know what it's like providing medical care when in lower income countries. My first job as a consultant was to be the director of the surgical intensive care at the Cambridge Military Hospital in Aldershot. And that was in the late 1990s. And since then, there's been a huge shift in ICU sedation practice. So why do we sedate patients? The first is treatment for disease processes. Going back to the head injury of Dr. Sanger's case, for a head injury, you might decide to take over the ventilation to ensure oxygenation and carbon dioxide elimination. As we know, these are potent problems for the brain when it's injured. Secondly, it can facilitate ICU therapies and the use of neuromuscular drugs. And as you will see later, neuromuscular drugs is a huge subject, and I shall only be touching it on briefly, as we may be able to do a little bit more on it in our presentation on airway management in December. The third is to try and reduce oxygen consumption. When we did the shock lecture, we talked about oxygen delivery. And quite often in critical illnesses, the balance between delivery and consumption is a big problem. So if you can decrease the work of breathing or reduce the ICP or paralyze somebody so that there is no movement, you will reduce the oxygen consumption. Occasionally, you'll meet an agitated patient, and an agitated patient is a huge problem because quite often the diagnosis is not known. and we will cover the reasons for agitation in a critically ill patient later. Fifth, there is the sad subject of palliation. As clinicians, we often regard preservation of life as the utmost aim. But every now and then you will get a patient that you know has got mortal injuries or illnesses. And once this is recognized, it is important that these patients have an end-of-life care that is befitting both ethically, morally, and clinically. And finally, the sixth reason for sedation is to allow procedures to be done. Procedures can be very painful, and I'm sure in the group listening to this, you have performed sedation in some form or the other, and I hope today will sort of give you some extra confidence in introducing new strategies to your armamentarium. Now, we talked about the reasons for sedating somebody in ICU. Delirium or a mental aberration or brain activity can be altered in infection, and this could be viral, bacterial, tuberculosis, malaria, etc., etc. Or it could be due to ischemia of the brain or other brain insults such as stroke. Drugs, whether these drugs were given in intensive care or medication that was in the patient before they became ill, can also cause an encephalopathy. Metabolic derangements like low blood sugars or high blood sugars, electrolyte abnormalities can also affect the brain. Other medical conditions like status epilepticus, stroke, temperature control problems like we've discussed in the past, like heat stroke or neuroleptic malignant syndrome, malignant hypothermia, or even a thyroid storm. But there are other causes of delirium that are modifiable. If you provide analgesia, the patient may be more calm. If the patient's got a sleep deprivation, because you remember sleep is vital for recovery, as we've discussed previously. And we know there is a diurnal variation in cortisol being lowest at 1 or 2 in the morning. And this is why it's so important to match our patients' level of sedation in intensive care to match day-night cycles. For the patient, the carers and the environment can be hostile because they are unfamiliar and frightening. They may wake up having been restrained because one wanted to prevent injury to themselves and to the carers. There's the sensory deprivation by having your eyes taped or your hearing protected by earmuffs. Or there might be a language barrier or inability to communicate with somebody who's deaf or blind. There may be also pre-existing factors like PTSD, drug abuse, dementia, alcohol, etc. that will result in a withdrawal and will manifest itself as a delirium. And obviously respiratory disease where there is retention of carbon dioxide or hypoxia will also contribute to this state. So what are the benefits of sedation? First is to reduce anxiety. Anxiety and pain coexist. It is difficult to separate the two. The more anxious you are, the more pain you experience. So you can see already the link between pain and awareness. It provides rest. It may help the patient sleep at night and be more awake during the daytime. It also reduces the distress of having a endotracheal tube or a tracheostomy, or having various invasive procedures being done and lines being put in. And finally, it does blunt the patient's awareness of the environment they are. And how are we going to provide the sedation? Well, drugs is an obvious choice, but what I'd like you to think also of the non-drug interventions that you can do that will help you achieve a better quality of sedation. Now, you've seen the Richmond Agitation Sedation Scale by Dr. Carter last week, and in his presentation, he also talked about the critical care observation tool when considering a patient for intubation and ventilation and for repatriation back home. And the critical care observation tool is another example of a scoring system which allows you to titrate the amount of intervention you need to do for the degree of intervention that is required for the patient to be safe and sound. But you will not be surprised that there are risks of both inadequate sedation and analgesia or an excessive amount. So let's look at the inadequate. We know that if you are stressed, the body goes through a stress response, of which the production of adrenaline and other catecholamines is well known to you. You can injure yourself. For example, a patient who's exhibiting psychotic behavior, you might have to restrain him to prevent injury to the patient and to the carers. It may be very uncomfortable for the patient, and this memory may manifest itself as PTSD during rehabilitation. It'll make it difficult for you to provide care for the patient. It increases oxygen consumption, and as we've talked, the balance between delivery and consumption becomes more difficult, and therefore the knock-on effect is to have an impact on oxygen delivery. Or the patient may be frisky enough and extubate themselves accidentally. And if the sedation is inadequate, then you may have to increase the sedation, and this may not match and titrate the sedation that is normally required. And if the patient is fighting the ventilator, it's either because the mode of ventilation is not appropriate, or it could be that the patient is trying to overrun what the ventilator is trying to do. And this increases the distress and causes dyssynchrony. On the other side is the risk of excess sedation and analgesia. Immobility complications. If a healthy person takes to his bed for 3 days, it is calculated there is about 10% loss of muscle mass. So just imagine a patient who's critically ill, say with a major burn, who may be immobile in intensive care for several days. You can now see why mobilization during the rehabilitation will become a problem as a result of the muscles not being used. Professor Wood, who is a professor of burns in Australia, when she went to look after the victims that were burnt in the Bali bombings, tried to mobilize the critically ill patients as soon as possible, even those who were intubated, to try and bring mobilization as quickly as possible. Another risk is contributing to the delirium, the impact of these drugs on the brain function. Another one, which is common, it can drop the blood pressure and heart rate, and for those patients that have a poor cardiac output or on the T-tree of collapse, giving inappropriate sedation analgesia might make the situation worse. Immunosuppression is a complex problem, but we know opioids reduce immunity. So this is why patients addicted with opioid medication tend to die early. Patients who are HIV positive tend to die early. And patients who are HIV and opioid addicts will die even earlier. So immunosuppression, especially in this time of the COVID pandemic, is a complex problem. If the sedation is excessive, it will also impair your ability to assess the patient, especially if it involves neurological assessment. It increases length of stay and costs that sometimes the patient may have to bear, and this may in itself be an inhibiting factor. Occasionally, you'll meet patients with the paradoxical effects where instead of being sedated, they become more alert and agitated. This is very similar to the impact of alcohol, which occasionally makes you socially disinhibited before you become sedated and then unconscious. If you are using sedatives for a long time, during the rehabilitation, there will be a prolonged hangover as the drug and its metabolites may still be within the body. We know that if you sedate or provide strong analgesia, there's a risk of respiratory depression, and therefore, by definition, the person providing the sedation must be able to manage the airway and take over the ventilation if that problem does arise. Tachyphylaxis is a subject I will discuss later in this presentation. And withdrawal is another clinical problem. Just like a chronic alcoholic withdrawing from alcohol, there is a similar effect when patients who've been sedated for a long period of time. The withdrawal of these drugs can be quite difficult clinically. Now, we talked about procedural pain, and I'm sure this is something that all of you have done. 10 years ago, Francis Young, then a medical student, now an anesthetist, and myself produced this chart, which in the colors of the traffic lights to illustrate the severity of the procedure in terms of pain, and on the x-axis, the duration of the procedure. And you can see if it's a short, reasonably pain-free procedure, you can just provide simple analgesics or even nothing. On the burns unit, we use oral morphine, but this it becomes a problem as it's difficult to titrate, and once the drug is in, it's in. And quite often, if there is no match between the procedure duration and the timing of the drug and the duration of the drug and its offset, then you can see there to be a mismatch. When you get to the yellow of the traffic lights, there are lots of possibilities. You've got the volatile agents like methoxyfluorine and nitrous oxide. In the UK, that is marketed as Entonox, the trade name. You can use morphine, or better still, fentanyl, either IV, sublingual, or by intranasal route. Ketamine, which is a brilliant drug with multiple routes of application, IV, IM, IO, and even intranasal. And then finally, in a long procedure, which is very painful, you would get your anesthetist to provide general anesthesia either with a volatile agent or total intravenous anesthetic known as TIVA. So nitrous oxide, it's one of the oldest patient-controlled analgesias, or PCAs. It is very effective and it's been used in labor for decades and other acute pain states. But prolonged use will cause a neuropathy and bone marrow suppression, and this is due to vitamin B12 and methionine and folic acid pathways. It is an anesthetic agent, but it's going out of use because of the contribution of nitrous oxide to the greenhouse effect. So you'll find modern day anaesthetists avoiding the use of nitrous oxide compared to the generation that I belong to that grew up on nitrous oxide as part of the anesthetic armamentarium. Methoxyfluorine is an inhalational anesthetic with analgesia in sub-anesthetic doses. When I started my anesthetic training in the 1980s, it was one of the volatile agents, which has now been supplanted by halothane and fluorine, sevoflurane, etc., etc. Unlike Entonox, it has a slower offset with good residual analgesia. In other words, you just don't get the abrupt return to pain after stopping using the methoxyfluorine. The reason why it went out of clinical practice is that methoxyfluorine is metabolized to fluoride, and fluoride is renal toxic, and there's a risk of renal failure. It has been used extensively in Australia for pre-hospital care and for procedural burn events. It's commonly known as the green whistle. If you do get a chance to look at this option, go onto the website and you will find very good educational material for this. We've also used fentanyl sublingually in the form of a tablet for post-burn hand therapy. Now, this is Amy Walton, our occupational therapist. This young lad, Christopher, was 19 when he was piloting his Cessna aircraft, and it crashed into a building, causing severe injuries and burns. Here you can see Amy trying to mobilize his fingers. People perhaps don't appreciate that function is preservation of function is a critical part of trauma care. I'm pleased to report that Chris not only made a good recovery from his burn injuries, but he also resumed flying, and more importantly, has started at medical school and is due to qualify in the next year or two. Now, if you are going to provide procedural sedation, you must make sure that you are competent to do so, that your patient selection is appropriate. Make sure that you are matching your sedation with the expected duration and severity of the pain that the patient may experience. A simple practical point is that if you're doing the procedure, before providing the sedation to the patient, get all your equipment ready that you need for the procedure, so that the time from providing the sedation to the time of finishing the procedure is kept to a bare minimum. This chart just illustrates the need for training, and you can study this in your private time, but the importance of BLS in anyone providing sedation is absolutely essential. So what are the common ICU sedatives and analgesics? Well, you've got your opioids, of which morphine and fentanyl are the most popular. You can use a benzodiazepine for sedation or for amnesia, and the favorite choice is midazolam. Or you can use an anesthetic agent, ketamine, which we've talked about, propofol, and another agent, dexmedetomidine, which we will describe in a moment or two. And finally, an antipsychotic like haloperidol. So if you think a patient's psychotic, or if you think the patient is very agitated and at a risk of harming himself or others, then haloperidol is a very useful option. So let's go back to the environment that we're talking about, the austere environment. The challenge of managing PAD, which is three components, pain, anxiety, and delirium, is very difficult. Why is it difficult? Well, you are legally, ethically, and morally bound to provide good PAD management from the point you meet your patient to the point of handing over, hopefully to an increasing level of care. And this may not be easy because other treatment priorities may conflict or take precedent or even overshadow the need for PAD management. And as we've discussed before, undersedation and oversedation are both bad for the patient. So the consequences of a poor PAD provision results in PTSD and poor pain control. Now, a paper published by Lisa Holbrook from San Diego in 2010 in New England Journal of Medicine showed that if an American Marine or sailor had a severe injury, if they got good pain relief by morphine, there was a 9-fold reduction in the risk of PTSD. Another challenge is the non-conventional transfer methods. A patient may be entrapped, or you may be in a environment that is difficult to cross with conventional methods like a stretcher or a trolley. And for these non-conventional transfer methods, providing analgesia may be very difficult. Just imagine transferring a patient with multiple fractures over a hilly terrain. And this provision of PAD is required throughout the journey until you reach a better level of care where the resources and the expertise is better than what you are providing. And the final benefit is the reduction in metabolic demands and the reduction in morbidity and mortality in these patients. So how do we classify PAD? Well, the drugs that we use can be either a sedative, an analgesic, or a drug that has both of these provisions. So where does pain management fit into it? Well, we consider pain management under D in the algorithm of catastrophic hemorrhage, airway, breathing, circulation, disability. You can use any pain scale, the traditional one of VAS of 0 to 10 or 0 to 100 or Wong-Baker faces, as long as you're making an attempt to measure the pain and the impact of an intervention, that's fine. In a military environment or in conflict areas, you may have to remove the weapons that may be with the patient. And then you can use the pain ladder. And the Department of Defense for mild to moderate pain recommends paracetamol and meloxicam. And you may recall in our field guide, we talk about paracetamol and ibuprofen. Just be careful when you give a non-steroidal to patients who are otherwise elderly or have comorbidity or are on concurrent medications that may contraindicate the use of non-steroidals. For moderate to severe pain, oral transmucosal fentanyl has now replaced morphine, and for shock or respiratory distress, ketamine either by a single bolus or my preferred option, small boluses on a regular basis, is both safe and effective. And you monitor the sedation by using the mnemonic AFBU, alert, verbally responsive, response to pain, or unresponsive. And going back to the PFC, minimum, better, best, your first option would be paracetamol with or without a non-steroidal, the second an opioid, and third an opioid plus or minus ketamine. paracetamol, a fantastic antipyretic, an analgesic, but it has no anti-inflammatory actions. So that means for somebody with osteoarthritis or rheumatoid arthritis, it won't be as effective as a non-steroidal. However, it has an added safety in that it doesn't have that much risks of bleeding, cardiovascular events, or renal toxicity. The dose is 1 gram every 6 hours, and we try and limit it to 4 grams a day to avoid hepatotoxicity. But in the elderly, we may drop it down to 3 grams a day, as their renal and liver function may be reduced. And the beauty about paracetamol, it can be given orally, rectally, and also intravenously. Intravenous paracetamol, especially in major trauma, will reduce the amount of morphine that a patient requires. But the cost of intravenous paracetamol is huge, and it is unlikely to be available in low resource countries. The non-steroidals, very effective analgesics, and more importantly, fantastic anti-inflammatory agents, and they work by inhibition of the cyclooxygenase pathways. But it also affects platelet activity, renal function, liver, and cardiac dysfunction. So be careful about using it in major trauma and major burns. In fact, I would say do not use a non-steroidal in the acute illness, because the advantages is completely overwhelmed by the disadvantages. Now, here are 4 non-steroidals that are recommended. The thing that I want to point out to you, which is slightly unusual, is that ibuprofen does have some antipyretic effects. Naproxen is particularly good for post-procedural pain, especially if it involves things like fractures. And meloxicam, being a COX-2 inhibitor, is very useful in low income and resource limited states. Opioids, morphine is your classic opioid, but it causes vasodilatation, so we have problems in patients who are in shock or patients who are asthmatic because of the risk of releasing histamine, which can result in bronchoconstriction or urticaria. I can't remember the last time I used morphine in an acute injury. My preferred choice is fentanyl. But if you use fentanyl, you will note that there will be a bradycardia. And if it's given as a rapid intravenous bolus, the patient will experience for several minutes a rigid chest wall rigidity, and patients describe it like a tight bodice with great difficulties in breathing. It's very potent, rapid onset, and has much less chance of hypotension or histamine release compared to morphine, but it's very useful as an intravenous infusion. Ketamine is a brilliant drug. It works on the NMDA receptor, N-methyl-D-aspartate receptor. It can be used on its own or in synergistic effect with other opioids like fentanyl. It can be given intranasally, IM or IV or IO, but is limited by the psychomimetic and dysphoric effects, where sensation of sound and sight can be magnified, which is why it has become a drug of abuse. And patients who have undergone ketamine treatments are usually nursed in a calm, dark environment so as to reduce the dysphoria. Patients who abuse ketamine as a form of in the form of an addiction will get contracted bladders, and this is irreversible. But if you're using ketamine, remember it has a synergistic effect with opioids or other sedative drugs. Now, you remember the Richmond Agitation Sedation Scale. This was described by Dr. Carter in his presentation last week. And in his presentation, he also described the critical care observation tool. So if you get a chance to go back and look at his lecture, I find it a good tool to use when a patient is intubated, and it's simple and it's easy to use clinically. Now, in this scale of RAS, 0 is an alert and a calm patient, and if you go into negative numbers, your level of consciousness is going down, and if you are going into positive numbers like +4, the patient's combative, violent, and danger to staff and himself. So depending on the clinical scenario will dictate what level of target RAS score you're trying to aim for. Here, I just want to digress for a moment. Anesthesia has always been taught as a triad of hypnosis, which is providing sleep, 2, analgesia, and 3, muscle relaxation. The only time you need muscle relaxation is that if you need to intubate the patient, or if you are opening up a cavity like the chest, the abdomen, or pelvis, or if it's a long, painful procedure, or the patient is going to be placed on the operating table in a difficult position where airway may be compromised. So when you're providing PAD, you're basically providing hypnosis and analgesia. But there is a fourth component I would like you to be aware of, and that is autonomic homeostasis. What does that mean? Well, we know that the body's autonomic nervous system is twofold, the sympathetic and the parasympathetic. And which system rules depends on what is happening to the patient. So if you are in flight and fright, the sympathetic nervous system is dominant. But if you have had a large meal and you are becoming sleepy, it's because the parasympathetic nervous system is now dominant, and digestion and absorption of food material has taken over. Now, when you talk about anesthesia, the difference between anesthesia and analgesia has been hinted when we talked about nitrous oxide, methoxyflurane, etc., etc. But you can also provide local anesthesia, either topically or a nerve block, or if you experienced a regional anesthesia or a central neural blockade, which is what anesthetists do with a spinal and epidural. And then finally, a general anesthetic, either using a volatile agent like enflurane, sevoflurane, or total intravenous agents. And the patient can either breathe on their own, or if you're using neuromuscular blockade, the patient's breathing must be taken over and the patient ventilated to an autonomic homeostasis. What does that mean in practice? It means keeping the heart rate, blood pressure, oxygenation, carbon dioxide elimination, temperature, all within normal limits. Before you sedate somebody, you need to consider what the particular sedation is going to need. What is the patient like? What's their physical and physiological status? Are they stable, or is it an ever-changing situation? There may be operational needs. What is your aim? Is it just analgesia, sedation, or both? How long is your procedure going to take? Remember, I said to you, before you provide a pad, make sure that all your equipment for the procedure, things like swabs, nursing packs, etc., are ready to go so that the time from providing sedation to the time of finishing the procedure is kept to a minimum. Then you need to make a choice of your cedar analgesia, and this will depend on your expertise and what is available to you at that location. You may decide to pre-medicate the patient, like the use of opioids or benzodiazepines, particularly for amnesia, usually retrograde amnesia, or for anxiolysis. We've already said that if you are sedated, your respiratory efforts are curtailed and you have a risk of desaturating. And so you are trying to maintain the patient's saturation above 95%. But this is assuming that the patient is normal in the first place. So you're going to have to make adjustments for the patients with chronic heart and lung disease. Finally, the provider factors. You may be the sole provider of the sedation and performing the procedure. Or you may be lucky enough to be working in a team. It will also depend on your competence, your experience, and whether you're allowed to do a particular procedure or provide the sedation. You will also need to consider the availability and resupply of medication and equipment. And the monitors, I use the mnemonic SOAPME, suction, oxygen, airway devices, pharmacology, and monitoring equipment. And the most important monitor is you. You observing the patient is the best monitor. If you're on your own, make sure that you've got top cover and get help from a senior colleague. And remember, when you're providing sedation, you must be able to handle the complications like loss of airway, blood loss, or stability of the autonomic nervous system. Now, you'll be familiar with this JTS CPGs on pad 1. I'm not going to go through it all, but just to show you that you can see the different levels of RAS scores you're trying to achieve, depending on whether a patient's intubated and unstable, or intubated and stable, or if they are not intubated and are stable. But the thing I would like you to concentrate on is right at the bottom, the use of adjuncts. Having a dim room, a calm environment, you providing reassurance to the patient, perhaps some nice background classical music, the presence of family and friends, and obviously adjusting the level of analgesia provided by the regional anesthetic. And this is made even more clear when we talk about maintaining the day-night cycles, considering an afternoon nap, use of earplugs at night so that they're not disturbed by the noise of the alarms and infusions and conversations, trying to use as least amount of sedation, and if at all possible, avoiding benzodiazepines that may have a hangover effect. To try and mobilize your patients early and getting an interaction with your patients. Remember, hearing is the last sensory input to go and the first to recover. So talking to your patient, even though they may be unconscious as far as you can work out, is useful, because quite often patients in the rehab phase will comment on the impact it had of reassuring that things were fine. Dexmedetomidine is used for sedation or sleep at night because it is a quick onset and offset. And what might be a little bit surprising to you is a use of quetiapine, which is a non-classical antidepressant. And I would like you to read about it as it can be very useful. Sedatives, the ideal one should have a rapid onset, short duration, quick offset, and minimal side effects. But it has no analgesia. The downside is that it can cause vasodilatation and myocardial depression. So this is why, as you require more and more intervention or providing better care, you can see the use of benzodiazepines intermittently, going up to ketamine and or propofol, and then finally dexmedetomidine. Now, neuromuscular blockade is used in certain circumstances, like in providing a advanced airway, in intubating the trachea, either orally or nasally, or you might need it even in a patient that is being ventilated via a tracheostomy tube. The need for in AOE is rare, but if you are going to use these drugs, you must be able to ventilate the patient mechanically. And remember that if a patient is paralyzed, they are unable to respond, and there's always a risk of awareness. This is why it's important to think of the anesthetic triad of hypnosis, analgesia, and muscle relaxation. Awareness can occur in clinical scenarios like endotracheal intubation in an emergency cesarean section in obstetrics, or intubation for major trauma and burns. Benzodiazepines are our first choice of sedation. They work by increasing GABA receptor activity, which is a negative effect, thus reducing CNS activity and providing sedation. It also is an anxiolytic, i.e. reduces anxiety, and is an anticonvulsant. But like I've said earlier, respiratory depression, especially in synergistically with opioids, can cause cardiac problems and decompensation, resulting in hypotension. Of the three drugs listed here, midazolam is the one that is most useful because of its rapid onset and short half-life. Ketamine is an NMDA receptor antagonist and provides analgesia and sedation while preserving cardiovascular and respiratory function. I like to regard it as a sympathomimetic drug. That is, it reinforces the sympathetic rather than the parasympathetic nervous system. It produces a lot of saliva, and therefore to dry up the saliva you may need glycopyrrolate or atropine. There is an emergence phenomenon, so sometimes a low dose of 1 or 2 milligrams of midazolam is given in addition. It does, however, lower the seizure threshold, but does not increase intracranial pressure. Now, you remember the case from Dr. Sanga in Tanzania. He talked about the head injury. When I started training, we were told you couldn't use ketamine because the sympathomimetic effects may embarrass the blood flow to the brain. But this has been proven to be not true. It's a brilliant bronchodilator, so you will not be surprised that ketamine is a drug of choice for intubating asthmatics or for the use in septic shock. Propofol. This has become an infamous drug ever since the death of Michael Jackson. It is not a white drug. The drug itself is colorless, but it's made white by its compounding with egg and soybean. It can cause vasodilatation and hypotension, and is known to cause a myoclonic activity, little muscle jerks, but surprisingly enough, it can be used for refractory seizures. It has no analgesic activity, and it's an induction agent because in 1 arm brain circulation time, it puts the patient to sleep. It is also used as an infusion, but you have to be really careful because it contains fat and can contribute to lactic acidosis load. And in my lecture on shock, I gave you a slide on the lactic acid production, the causes, and the management. So we are very careful not to use propofol infusions for a long period of time. It is good for transfers or where you have to lighten the patient's sedative level to do neurological assessments, or for very quick, short procedures in refractory status epilepticus and for intubation. Now, dexmedetomidine is a selective alpha-2 adrenergic agonist. It has to be given slowly because for a transient period of time, it increases the blood pressure. It works by sympatholysis at the central and peripheral adrenergic receptors. It causes a relative bradycardia, so you're not going to use it in drugs that affect the AV node like the beta blockers, or if a patient's already bradycardic, like in very healthy athletes, or in a state of hypovolemia or reduced cardiac output. But it is particularly useful for delirium or agitation, or when you're trying to wean a patient off a ventilator. It can either be given by a slow bolus over 5 to 10 minutes or by an infusion titrated to the level you require the patient to be at. So we've said that neuromuscular blockade drugs are used for endotracheal intubation, for complete immobilization, say for transfer over very hilly terrain, or for mechanical ventilation. But these drugs can only be used if the person using the drugs can perform advanced airway management and take over mechanical ventilation. We've talked about the risk of awareness in high-risk states like trauma burns and in cesarean sections. But the other problem is the prolonged polyneuropathy of critical illness. Drugs like vecuronium, which is a aminosteroid compound, is now known to cause a polyneuropathy, and so this is the reason why there is care in using these drugs long term. There are two kinds, the depolarizing, of which succinylcholine or succinylcholine is the classical one. This drug needs to be kept refrigerated, which means using it in low resource areas is a problem. It's a drug that has lots of side effects, one of which is malignant hypothermia and muscle fasciculation, and therefore modern day anesthetists tend to use high-dose rocuronium instead. We'll hopefully be covering a little bit more detail on these drugs on my talk on advanced airway management in December. So what are the other adjuncts? Well, the non-drug ones are really important. The first is your ability to communicate with the patient, providing reassurance, splinting of fractures, elevation of a limb that is damaged or burnt, the application of heat or cool. Application of cling film on a major burn is a brilliant analgesia. Other adjuncts, if you are qualified, would be regional nerve blocks. Right at the start of this lecture, I mentioned tachyphylaxis. What is that? It's a decreased drug's effectiveness if used for long periods of time. Quite often, it's not realized, but if you're having to increase the amount of drug or infusion rate or bolus, then think about tachyphylaxis. Why does it happen? Well, either because the body is metabolizing the drug very quickly, or the fact that the receptor itself is downregulated and is not as effective as it was initially. And this has considerable individual variation. And one way of tackling it is to use a different drug. So you may be running the patient on a fentanyl midazolam infusion. And if you think tachyphylaxis is a problem, you may consider using, say, ketamine by infusion. Finally, in rare cases, you may have to provide palliative care. It's a subject that nobody likes talking about. In our undergraduate program, I gave a talk on palliative care. Because if you plan, and then you're likely to be able to provide good palliative care in those rare occasions where somebody's life is at an end. So we're not now talking about preservation of life ambition in clinical practice. We're talking about providing good quality of dying. Because death of a patient doesn't finish there. You have to remember that the patient's family and friends will only start their problems with grief, and your ability to ensure and inform the family and friends that they had a good quality of death will be a huge relief to them. Palliative care is actually symptom care, and pain is the most obvious one, but things like anxiety, respiratory distress, nausea and vomiting, etc., may all need to be addressed. If it is at all possible, think about spiritual care. Spiritual care is not religious care. When I'm asked what is spiritual care, I give the example of somebody who has just been told they have a chronic health diagnosis that's going to have an impact on them for the rest of their lives, like diabetes or HIV, or they have got a diagnosis of a cancer with a life expectancy of weeks or even days. It's when the patient then says, "Why me?" That is spiritual care. And no analgesia or sedation is going to reduce that. You may be able to provide spiritual care by touch, by reassurance, by asking them if they need the intervention from a priest or friend or family. These are all important. But please don't forget about yourself. I know very few people that have looked at palliative care in clinical practice without having some impact on their feelings or emotions. Reversal agent. Well, for the opioids, you've got naloxone. For benzodiazepines, you've got your flumazenil. And for the non-depolarizing neuromuscular blockade agents, you've got neostigmine or sugammadex for rocuronium. When I'm asked how much of a reversal agent you need to give a patient, I say enough, because it's got to be titrated to response. And you can see at the bottom, I said the use of a reversal agent must be flagged as a critical incident. It is because you have overdone the use of the drug, whether it's fentanyl or midazolam. And reversing it means that you will get the pain back if it's an opioid, or make them agitated if it's a benzodiazepine. So reversing an opioid, reversing a benzodiazepine can result in problems. And that is why I've highlighted it as a potential critical incident, and that needs review. So finally, what do I think is the best potential agents for provision of analgesia and sedation in the osteo environment? Well, of the 5 drugs here, I think the majority of your choices will be done by just 4 agents: morphine, fentanyl, midazolam, and ketamine. Try and become familiar with, say, fentanyl and midazolam to begin with, and make sure you learn it from an expert and practice the first few times you do it under supervision. Remember, we're talking about patient safety at all times. Well, good luck in your analgesia and sedation provision in your clinical environment. And when you do your Gibbs reflection later on, try and pick up at least one practical point that may be useful. Let's say we're using fentanyl and midazolam as your PAD provision. Which do you give first, the fentanyl or the midazolam? I'll just give you a second to think about it. Well, fentanyl and midazolam, when used together, are synergistic. Not additive, synergistic. So the optimal approach as to which drug to be given first is the opioid. So you give the fentanyl bolus slowly, give it a couple of minutes to work, then give a small bolus of midazolam, say a milligram to begin with in a frail patient, or maybe 2 milligrams in an otherwise ASA1 status patient. How do you remember that? Well, fentanyl is an opioid and midazolam is a sedative. The letter O comes before S. And my challenges to you is when you next are in a clinical environment and fentanyl midazolam is used, see if the provider uses an opioid first and not the sedative. So all that remains for me is to wish you good luck for your provision of analgesia and sedation in your clinical practice, and I look forward to receiving your Gibbs reflection. Thank you.
It's okay.